my distinct pleasure to welcome today's speaker, Dr. Elliott Miller, to our pulmonary grams today. And as you can tell, I am not Elliott. Unfortunately, Elliott is feeling under the weather, but he's, being the trooper that he is, has joined us online. And so this will be a truly hybrid endeavor. But before we get rolling, I'd love to introduce and tell you a little bit about Dr. Miller. So Elliott had his undergraduate studies at UNC Chapel Hill, medical school at Georgetown, after which he moved to residency at Johns Hopkins. He then became a critical care fellow at the NIH, which was followed by a cardiology fellowship here at Yale, at which time he obtained his MHS. As you may recall, we have a very, very special and personal tie to Elliott, as he became part of our MAKU team during the first COVID wave in the spring of 2020, towards the end of his cardiology fellowship. Remember those days? For some of you, maybe, when we had patients on NP9, 10, NP12, and NP15. Not to try to give people PTSD, but he served as team leader for auxiliary ICU COVID teams given his critical care training. And I remember that particularly with gratitude, as he was one of the very first people to raise his hand and volunteer to help, which really does speak volumes about his integrity and sense of responsibility. So it's no surprise that Elliott was then selected to become the medical director and firm chief for the CCU shortly after joining as faculty in 2022. He has since received numerous accolades and awards, such as the Emerging Investigator Award from Circulation and teaching awards from both the Internal Medicine Department and through the School of Medicine. As a testament to his skills as an educator, Elliott is a sought-after speaker both nationally and regionally. He's a rising star in the fairly nascent field of critical care cardiology and really well-positioned to steer innovation, further education and research, and improve the lives of patients with cardiac disease. And he's able to do so because he serves on really impactful committees, such as the executive board member of the Society of Critical Care Cardiology, investigator for the Critical Care Cardiology Trials Network, and now co-chairing the Critical Care Cardiology Council Research and Publications Task Force at the ACC, just to name a few of his administrative and leadership positions. He's written widely on topics related to cardiac critical care in distinguished journals such as Critical Care Medicine and JACC. His lecture today is titled Cardiac Critical Care, Update for the Medical Intensivist. Please welcome Dr. Elliott Miller.
Thank you, Dr. Honidan. That was a really lovely introduction, and I'm so sorry I couldn't be there in person. Everybody, kind of in the line of the COVID mention, I had a fever this morning, so I thought I would spare everybody and just do this virtually. So my apologies. All I can see is the CME numbers. So if you're very disappointed with the talk, I'll just never know. But as Dr. Honidan mentioned, I'm going to be speaking about cardiac critical care. And a special thank you to Dr. Matei for the invitation and for the prompt on what to talk about. So I hope this is of use to both the cardiologist or the faculty that see an enormous amount of acute cardiovascular disease, as well as the fellows, especially if they end up in a mixed MICU. So I have one disclosure with Fisher and PayCal, research funds from them, and I'll talk about this a little bit later in the talk. As a way of outline, I'll talk about the evolution of the CICU patient population briefly, resurgence of an old critical care friend, updates on shock phenotyping, and then I thought it would be of interest to the group to talk about updates in mechanical circulatory support and kind of where the technology is going. So the CICU or the CCU in particular, was first thought of back in 1961 when a British cardiologist named Desmond Julian presented his work to the British Thoracic Society. And he more or less reported a quality improvement project when 4 out of 5 of his recent AMI patients died of cardiac arrest. And he described all of the problems that he encountered, both not having a dedicated unit, delays in care, lack of expertise, both from a nursing and a physician standpoint. And he more or less just described the coronary care unit, which basically up until the 2000s is what the CCU was, a post AMI care and monitoring unit. But as many of you know, that has changed over the last 2 years or 20 years. So this is a nice figure actually from an editorial that went along with the literature on the right, where David Morrow from the Brigham took individual publications, these red bars, and showing the proportion of STEMI admissions to CICUs across different sites, Duke, NYC, UVA, Medicare. And then on the right was the accompanying data from the article showing that as of 2013, that the primary admission diagnosis for Medicare patients over 50% was a non-cardiac diagnosis, which is what we're seeing in the modern CICU. More recently is data from the Critical Care Trials Network, which Yale is a part of. And I'm going to mention it several times during the talk. It is now includes over 40 level 1 CICUs across the country, including Canada and the UK. And it just as yesterday heard that we're adding a site in Brazil. This is one of the earliest publications where we detailed essentially why are patients being admitted? What are the indications for admission to the CICU? And most of them you'd expect cardiogenic shock, arrhythmia, cardiac arrest. But I think what surprised a lot of people was that the number one reason for admission to the CICU is respiratory failure. We looked a little bit closer at this a year later. And each bar represents the proportion of patients requiring respiratory support by diagnosis, common diagnoses you'd expect, cardiogenic shock, acute heart failure, valvular disease, pericardial effusion. The blue represents invasive mechanical ventilation, orange is non-invasive, and then the green is high flow nasal cannula. And you can see that the proportion of patients that require some form of respiratory support is different, but overall, over a third of patients will require some. And I will bring this back towards the end of the talk a little bit. Next, a little bit about resurgence of an old critical care friend, and this would have been more fun to ask the audience in person. I assume many of you would have guessed the pulmonary artery catheter. On the right here, this is Swan, and on the left is Gantz, and one of their first tracings. For the medical historian, Swan actually more or less was kind of being laughed out of the profession because he'd been trying to do this for years, mostly in animals, and all of his lines kept on coiling in the RV. And he was out in San Monica Bay watching sailboats go by, and he devised this potential device that would be flow directed, and the rest is history. And we've been using this for over 50 years, although there's been a lot of ups and downs. And this group probably knows more than most a lot of these ups and downs, because some of the first evidence that PA caths don't improve outcomes actually were from the medical ICU. On the far left, the support investigators in 1996 looked at 5,700 patients in the medical ICU at 5 sites, and they found actually an association between right heart caths and increase in mortality and resource utilization. Rhodes, Pac-Man, more ICU, medical ICU studies showing essentially no difference in PA cath use. Escape here at the bottom, also in 2005, is more or less a self-imposed wound from the cardiology group. This was all-comers heart failure, which showed no difference in outcomes, but notably did not include patients with cardiogenic shock. Fact is, your acute lung injury, no difference, PA caths, and then unsurprisingly, both cardiovascular ACC/AHA guidelines as well as critical care guidelines recommended against routine use of PA caths. This study is actually from Yale investigators. I know many of you probably know Nihar Desai. Um, Similarly, from the same study, this trend was probably most pronounced in respiratory failure in the medical ICU, but it included AMI patients and acute heart failure patients as well. And there's a small little increase in 2013, and we've probably seen that increase since. So one of the notable issues with those prior studies is they largely didn't include cardiogenic shock. And this has become probably one of the hottest topics in the last 4 or 5 years in critical care cardiology. This is a nice study from the second registry that I'm going to mention a fair amount. They are called the Cardiogenic Shock Working Group. They're out of Tufts, and they include over 10 higher tier CICUs across the country. And in this study, they looked at patients that got no PA cath study, an incomplete assessment, or a complete assessment in gray before a mechanical circulatory support device was input. You can see pretty wide variability across here. The main take-home point is at the bottom that in their overall patient population, if you got a full complete assessment with a PA cath before MCS utilization, their mortality was lower. And we found that patients that were SCI stage D and E in particular seemed to have better outcomes. I'll talk about SCI staging a little bit later during the talk. But the important part here is just that these are the sickest cardiogenic shock patients. And this persisted after multivariable adjustment. This is a couple years later from the Critical Care Cardiology Trials Network, where we looked at both utilization of PA caths, we looked at predictors of PA cath use, and then outcomes as well. On the left is the proportion of patients receiving a PA cath for shock. The red represents patients with cardiogenic shock, and the blue represents patients with all shock, including things like mixed shock, which represent at least 20% of our CICU patients. And you can see each line is a different CICU site, an enormous variability, ranging anywhere from 8% of patients all the way up to 73% of patients. Next, we looked at the main drivers, just including over 2,500 patients with cardiogenic shock. And unsurprisingly, patients that required some form of mechanical circulatory support were more likely to get a PA cath, a previous diagnosis of heart failure. But what surprised a lot of people is actually site level variation was one of the biggest drivers. Next, we looked at the association with outcomes, and we found that both in unadjusted and adjusted outcomes, use of a PA cath in patients with cardiogenic shock was associated with a reduction in mortality. Now, this is some work from our group here at Yale. Revision is currently under review. We used Vizient database, which is an administrative database that pretty much everyone here has access to, and I would highly recommend if you're unfamiliar with it to reach out to me after. But essentially, it is, think about national inpatient sample only with time-stamped labs, time-stamped procedures, and time-stamped medications. And we were interested not in the relationship between patients receiving a PA cath versus not, because I think that's a much different patient population, but actually the impact of timing on PA cath utilization. And so we identified over 600,000 patients with cardiogenic shock and found that 164,000 of them received a PA cath during their admission. And then we compared approximately 45,000 patients that received the PA cath on day 1 versus 28,000 that received the PA cath on day 2. In unadjusted mortality at the top here, you can see there was no difference, approximately 27% mortality. But after using inverse probability of treatment weighting and some fancy statistics, we found that actually there was a 4.2% weighted mean reduction in mortality, you getting a PA cath on day 1. And we looked at multiple different subgroup analyses, including stratified by initial lactate level. We stratified by only patients receiving mechanical circulatory support, excluding patients with out-of-hospital cardiac arrest, as their mode of death is usually brain injury as opposed to pump failure. We looked at primary admission diagnoses and then again our overall cohort and found a pretty consistent trend in improved mortality with PA cath use. Now, all three of those studies, including the unpublished work from our group, are all retrospective, observational, one administrative, the other two registry, and so with clear flaws. But we should have more evidence soon. So this is the pulmonary artery catheter and cardiogenic shock trial, or PACS trial, being run out of Tufts, which also runs the cardiogenic shock working group. So many of those sites are enrolling patients. This will be only heart failure cardiogenic shock, and they're randomizing patients to early PA cath within 6 to 24 hours, or no or delayed PA cath use after 48 hours. Primary outcome will be in-hospital mortality with an estimated enrollment of 400, and then hopefully some results sometime in 2026 or 27. But until we do have these randomized data, most expert opinions say that you need a PA cath with cardiogenic shock. In particular, if you're not exactly sure what's going on, maybe there's a mixed component, and if you have a mechanical circulatory support device, which is pretty consistent with what we do at Yale. Next, I'll talk a little bit about updates in shock phenotyping, and I know you guys have been doing this for ARDS for years and years. We're a little bit slow on the uptake, and this is probably the classic cardiogenic shock criteria that maybe even taught to house staff in the last year. And you wouldn't be wrong to do this, because this is what almost every shock trial since 1999, in the original shock trial to the ECLS shock trial, which I'll talk later in 2023, used to enroll patients in their randomized control trials. And it was simply just a systolic blood pressure less than 90 for at least 30 minutes, or needing a vasoactive med to maintain that blood pressure. Signs of end organ perfusion issues, altered mental status, cool extremities, oliguria, elevated lactate, and then of course, elevated filling pressures. But we know that shock in general, and cardiogenic shock, it's much more complicated. This was a nice editorial from Jake Genser, a friend at Mayo Clinic. And then top left, you see that we've learned a lot about different stages of shock, the sky shock stages, which I'll talk about in a little bit, differences in shock trajectory, hemodynamic measurements that we're using, both echocardiographic and from the PA cath, things like CPO and PAPI beyond our classic cardiac index or cardiac output. We're also learning a lot about phenotyping, whether this is an ischemic etiology, non-ischemic. Is this an acute AMI shock or someone that's got acute on chronic failure? Is this biventricular or univentricular failure? Cardiac arrest adds a big component to this as a risk modifier, and some work out of our group actually that the use of respiratory support is probably one of the biggest modifiers. And we're just learning this a lot more complicated. This study is from the cardiogenic shock working group, and in it, they use machine learning techniques to find clusters. And what they did was they used just the acute AMI cohort from their registry, and then using these 28 hemodynamic and metabolic variables, tried to find matching groups. And then they validated this in a Danish shock registry and their heart failure patients from the cardiogenic shock working group, and found three unique patient populations, which they defined as the non-congested, the cardiorenal, and the cardiometabolic. And I think notably found three markedly different mortalities for all three groups. I'd say that this is hypothesis generating and being used in research, but less clinically useful at the moment. More clinically useful, and both from a research and clinical perspective, is the SKY shock staging, which I've mentioned a few times. And I'll say that we use this terminology even within the hospital when we're talking to each other about patients. It was first brought up and published in 2019, and then updated in 2022. And just like the New York Heart Association classes, they've basically taken that strategy and come up with 5 different sky stagings. So A is your at-risk patient. They're not experiencing signs or symptoms of cardiogenic shock. Maybe they came in with a large anterior AMI, or they came in with decompensated heart failure. The beginning is that patient that's maybe hypotensive, but not hypoperfusing, which is a key component of it. So they've got a normal lactate. C is your classic cardiogenic shock patient. They're on Levophed, maybe an inotrope, maybe even a balloon. D is your deteriorating patient that's failing those initial therapies. And then E for extremis is your refractory cardiogenic shock patient or impending collapse. We're learning more about the importance of these sky staging and then also early changes in sky shock staging from a trajectory standpoint. This is more data from the 3CTN registry, where we looked at sky staging between 0 and 6 hours of admission, and then again at 6 to 12 hours after admission. And we looked at patients' trajectories on the left here. Did they worsen? Did they go from B to C? Did they weren't changed? Did they go C to C? Or did they improve? Did they go from D to C, etc.? And on the right, we looked at improved in green, stable in blue, and worsened in red. And you can see both in the AMI cardiogenic shock and heart failure cardiogenic shock patient populations, markedly different mortalities between the 3 patients. And when we did multivariable logistic regression to look at these outcomes, the predicted mortalities were even more stark. So if you had a worsening sky stage in the first 12 hours, your predicted mortality was 68% versus 13% if it improved, regardless of the stage. Next, I'll talk a little bit about our mechanical circulatory support devices, notably the Impella, balloon pump, ECMO, and then we've got some right-sided devices. And then I'm going to leave out durable mechanical circulatory support for this talk. There used to be the HeartWare, HeartMate 1 and 2, and basically the only thing we're implanting now is the HeartMate 3. You will see some 2s around, but basically there was a arms race between these 2 companies, and HeartMate 3 seemed to win. But I wanted to talk about the short-term devices because that's really where we're seeing the newest and most information. All right, balloon pump first. So you're probably all familiar with the IBP Shock 2 trial published in 2012, which randomized 600 patients with AMI shock, which is an important caveat, to either a balloon pump or medical therapy. In both at 30 days and 1 year, there was no difference in outcomes. And this led to a really a drastic change in the recommendations, especially in Europe, where they gave a class 3 do not use for routine use in Europe. And there's a lot of epidemiologic studies showing that balloon pump use in Europe, especially in Germany, went to almost 0. Caveat is still modern day, about 80% of cardiogenic shock patients in the US will get a balloon pump. But there was still hope for the chronic heart failure patient, which is a markedly different pathophysiology. The AMI shock patient might actually have a normal, even reduced SVR just due to the inflammatory milieu that they see. The chronic heart failure shock patient has a markedly elevated SVR and is treated completely different. This is both nice and probably one of the most cited papers for the potential benefit of chronic heart failure shock in balloon pumps. It's out of Columbia. They used 5 years of retrospective data. And on the left is a matched AMI cardiogenic shock patient population in this orange. And each line represents a patient. And then on the y-axis is change in cardiac output after the balloon pump went in. And you can see that overall, it was pretty null, right? The average showed no difference in cardiac output for this patient population. Half did worse, half did better. But if you look at the chronic heart failure patient, there's a small proportion that did worse, but overall, everyone seemed to do better. And then there's a group that got more than 1 liter per minute increase in cardiac output with the balloon, those that we've termed super responders. The book answer really for the increase in cardiac output with the balloon is 0.5. So receiving an increase of 1 liter is pretty impressive. And a lot of work has gone into who are these super responders for chronic heart failure. And this was a nice review article that looked at different determinants of who's going to really respond to a balloon pump. On the far left, patients with really low cardiac indexes don't seem to respond for what you'd expect. The pump needs a pulsatility to actually work. So if you've got really terrible shock, balloon's not going to work. That makes a lot of sense. If you've got RV failure, it's not going to support the right side of the heart. The SVR, the patient with the high SVR, this is perfect for the balloon. That number ranges in the literature, but in general around 1400. The patient with moderate to severe mitral regurgitation seems to respond really well. Again, the balloon's creating afterload reduction. And then the patient with relatively low heart rates, 92 has been kind of that number in the literature, but we see a response anywhere less than 110-ish to 120th. When you start getting higher than that, especially with rapid AFib, the balloon ends up just being more of a problem. We're also learning, this is some literature from Duke, this is under review as well, that it's more important than just does the balloon work or not work, but more about how the patient actually responds to the balloon. So they really elegantly looked at all of their patients receiving a balloon pump in both their heart failure cardiogenic shock in this kind of red, orange, and AMI cardiogenic shock, and actually found a markedly different response for diastolic augmentation and differences in outcomes for patients that actually respond well to balloon pumps. So this is hypothesis generating, but important to know that you can't really change how much output you get once you start the balloon. So response to the balloon is really important. So all of these things led to the alt shock trial, which just came out this year, actually in the last month at ACC. And what they did was they planned to enroll 200 patients with heart failure, cardiogenic shock to either a balloon pump or medical therapy. Their primary outcome was 60-day survival or heart transplantation. And as you can see, enrolling only 100 patients, this was stopped early for futility and a p-value of 0.45. This was published in JACC and was pretty controversial for several reasons. The first is they expected a 20% difference in their primary outcome with the balloon, which I think is probably very optimistic, and why they only were planning to enroll 200 patients. They also enrolled approximately 30, and if you look really at the guidelines in the SkyShock guidelines, probably more than 30% of these patients were Sky Stage B. Their median lactative enrollment was less than 2. So basically, they took a lot of patients that were not showing signs of hypoperfusion and gave them a balloon. So it's unlikely you're going to make a marked difference in outcomes in that patient population. And although we've been waiting for this for years and years and years, likely will not change the current management of heart failure, cardiogenic shock in the United States. Next, I'll talk a little bit about microaxial flow pumps or Impellas, which have become the second most common device in the CICU. This is a little bit older data, but I think paints a really kind of accurate picture of what's been going on. So the Impella was first approved in 2008. The first device was at 2.5, which roughly correlates with its flow. And after showing a modest increase in cardiac index at 30 minutes only compared to the balloon pump in less than 30 patients, this was FDA approved. And you can see just exponential increased use year over year. And if anything, this has probably been an even steeper curve since 2016. On the right, over that same time span, these investigators looked at variability of Impella use. So the y-axis is Impella use in patients requiring mechanical circulatory support for AMI shock, and each line approximates one hospital. So you can see that all comers for cardiogenic shock requiring MCS, there's a huge proportion of hospitals that use 0 Impellas, and then some hospitals using upwards of 100%. So from 2008 all the way to 2024, 0 randomized data that these improve outcomes and enormous variability in their use. We can talk a little bit later about probably why that is. This is kind of just a rough rundown of what the different Impella devices look like, and subsequent devices are more or less easier to get FDA approved after the first 2.5. I'll just black out or white out the 2.5 and the 5 as those have been sunset. Really, the only things we use are the CP or 4.0, which has a 14 French and is placed femorally, so it has a long line that goes through the aortic valve, has an inflow in the left ventricle and then an outflow in the aorta. And then the 5.5, which has a 23 French and is placed by a surgical cut down in the axillary artery with a chimney graft. And we're using more and more of these as a bridge to transplant. I wanted to show you what the device looked like in case you hadn't seen one, and then also what the console looks like. Just like we have a balloon pump console, we have a similar Impella console. So on the right first, this is the Impella CP. This is the motor current at the top and the outflow. So roughly around this bend is where it goes through the aortic valve. This is our inflow, where blood is basically sucked up into the device using the principle of Archimedes' screw, and then ejected out the outflow. And this is the pigtail, which we can see a non-traumatic pigtail. On the left is what the console looks like. And I won't go too much into this, but we set a performance level or a P level, and then we get an estimated flow. So this is not directly measured. We get a max, a min, and a median. We use changes in this aortic waveform and LV waveform to troubleshoot the device and see how the device is working. And then we also have a motor current, which helps us to know if the device is in the right place. These numbers are zeroed somewhere in a lab. I don't even know where these are made, but these are not clinically useful, but large changes in them are clinically useful. So I mentioned that in 2008, the FDA approved this device and its subsequent family members, but really there was almost no data. There was less than 50 patient randomized controlled trial published in JACC in 2017 that showed no difference, but obviously way too small to show a difference in mortality for a cardiogenic shock patient population. And then several studies, including work from our group, showing potential harm with the Impella. So this included over 3,000 propensity matched patients from the Anthem insurance database. All of these patients had AMI cardiogenic shock and underwent percutaneous coronary intervention. And after propensity matching, we found that that death was lower, both index 30-day in 1 year in the balloon pump group compared to Impella, less bleeding and less dialysis, and no difference in repeat revascularization or stroke. More recently, there was the Danger Shock trial, which you've probably heard about, published in 2024 in the New England Journal of Medicine. This study included 360 patients and took 10 years to enroll. This included only STEMI cardiogenic shock patients, and they randomized patients to either the microaxial flow pump or Impella to standard of care. So this was not balloon pumps, which again, Europe largely does not believe in. So this is just medical therapy with inotropes and vasopressors. They excluded patients that were comatose, again, because the mode of death is usually brain injury and not pump failure for them. and then more or less controversially had a primary endpoint of 180 days all-cause mortality. And to their credit, had very little crossover. And as you can see that by the skin of their teeth with an upper confidence interval of 0.99 and a p-value of 0.04, found a reduction in mortality in the microaxial flow pump group with a number needed to treat of 8. What's become not controversial, but still unclear, is that if you look at 30-day mortality, there was no difference between the two groups, but these curves seem to separate long after the device has been taken out. The median device support time was 60 hours, which is somewhere around here. So why for this this increased mortality difference late is really not exactly clear. And if you dig a little bit into the study, there was some odd findings. So because of the slow enrollment, Denmark added 2 different sites in Germany and the UK. And you can see that their standard of care arm in Denmark, the mortality was exceedingly high. You flip 1 or 2 of these patients, and this is a not significant study. And probably most important is, although there is a mortality reduction, it comes at an enormous cost. So the blue represents the microaxial flow pump, or Impella. In red is the standard of care, and you can see the composite safety outcome occurring markedly more in the Impella group: more bleeding, more limb ischemia, 42% renal replacement therapy in this study, and more sepsis. So tough to argue with a randomized controlled trial, very curated, specific patient population, but does come at a cost. This was a neat study from, again, the 3CTN registry, where they took all of the inclusion and exclusion criteria from danger shock and figured out what proportion of real world patients would that include. And I've chopped out actually probably 70% of this figure just to make it fit on one slide, and included only 32% of STEMI cardiogenic shocks in a real-world registry and 5% of all cardiogenic shock admissions. So important study, but again, as long as you tailor the device to the right patient population. Since their main study, they've also put out several different important studies looking at different patient populations that may or may not benefit from it. So this recent study in JACC included outcomes stratified by age. The Impella group is in this orange, and the standard of care is in this blue. And right around the age of 77 seems to be this inflection point where if you're younger, you seem to benefit from the Impella with a number needed to treat of 5, versus older folks seem to have an increased mortality and favor the standard of care, which I think is actually very clinically useful. For whatever it's worth, there was no difference in their composite of complications by age, which doesn't make an enormous amount of sense, but it does help us clinically. So that's where we're at with at least the Impella group. And I'll just say that our biggest problem ends up being limb ischemia. And so there's at least 4 devices under development. It's not super important to know the names of these devices. For example, the Impella ECP. But all to say that they have super therapeutic levels of cardiac output ranging from 5 to 8 liters, and they come with a much smaller French size. So all of them are either a 9 or a 10 French. And just as comparison, the balloon pump is usually placed with an 8 French, and the Impella CP is currently a 14. What's neat about these, and they're all in different stages of human testing, is that after you place them in the 9 or 10 French catheter, they are self-expanding so that they can reach much higher flows, upwards of a 30 French expandable pump. Next, I thought the group would want to hear a little bit about ECMO, because I know you see that a fair amount, and there has luckily been some recent randomized controlled trials. The ECLS cardiogenic shock trial was done in Germany by the same guy that did the intra-aortic balloon pump trial. And in it, he included approximately 420 patients with cardiogenic shock, AMI cardiogenic shock. Primary outcome was 30-day mortality, and you can see no difference between the two. And then in the ECLS or ECMO group, way more bleeding, way more limb ischemia. I don't know if this will change our management in the US because the majority of their patients were Sky Stage C, about 50% of them. We use ECMO as a salvage therapy. The ECMO is terrible for the LV. Think about it as continuous ECPR. But in this group, they randomized, think of the patient that maybe is doing okay on a balloon or doing okay on levo and dobutamine or milrinone to ECMO. It's probably not going to save that person, and it's probably going to lead to an enormous amount of complications. All to say, huge trial, which is incredibly hard to do in the critical care space, but probably not going to change our management. This is a little bit older, including only 82 patients with ECMO, but published in the Lancet. I thought that this would probably be of interest to the group if you haven't heard about it. So this is looking at VA ECMO and sepsis-induced cardiogenic shock. What they did was took European patients and did a propensity match to 130 septic patients not receiving ECMO. The dotted lines represent patients that in the unadjusted results, and the solid lines are adjusted results. Red equals the ECMO group, blue is the no ECMO group, and at least in this small study, although again, Lancet found a reduction in mortality for this patient population, which I'm sure you run into a whole lot. More recently, this is under review, should be accepted in the next week. We use the ECLS registry just to show the proportion of patients that are receiving VA ECMO from mixed shock. And there was a huge peak in 2020. I'm not sure exactly what was going on around 2020, but and then a subsequent downtrend. But there are or at least centers using ECMO for your mixed shock patient population. I think it needs to be curated, and especially maybe the younger patient, but our group here seems to be a little bit shy. So altogether, what are the guidelines saying? These just came out in the last 2 months. The Impella now gets a 2A recommendation for STEMI cardiogenic shock, and the balloon pump in the US guidelines went from a 2B to now class 3 for routine use, which the authors love to highlight, as well as VA ECMO. I wanted to just briefly mention some right-sided devices because that's kind of one of the next frontiers. In the red box on the left are the 3 main temporary devices. The right is more surgical, which I don't see. On the left is the Impella RP, which is placed femorally, goes through the right side with the outflow in the pulmonary artery. Similar for the RP Flex, but this comes from the IJ. And then the Protect Duo here, which is a device we have at Yale. We don't have the Impella RP or RP Flex. This is placed in the IJ and can be hooked up to an oxygenator if you're having pulmonary issues or hypoxia. This is a huge device, 29 French, and also prone to a lot of complications, but we will use it. So next, I just wanted to talk a little bit about how the critical care cardiology world is thinking about the literature that's out there and how we need to come up with our own literature. We looked at randomized control trials from 2007 to 2019 in the top 5 journals in critical care, general medicine, and cardiology. And we looked at both inclusion and exclusion criteria of patients with cardiovascular disease, and also looked at the proportion of patients that had cardiovascular disease in their studies. And we found that approximately a third of critical care studies actively excluded patients with cardiovascular disease. Only a third reported whether a patient had cardiovascular disease or not. And in those studies, a very small proportion actually did. So it's left us thinking how we extrapolate our patients from a lot of the critical care literature that's out there. And in this recent editorial that was a partnership with the ACC Critical Care Cardiology Leadership section, as well as our counterparts in Europe, we kind of defined what the issues are. Issues with informed consent, which I know that critical care cardiology or just critical care medicine trials run into. Cost is a huge issue, especially for device-related trials. The Danger Shock trial, again, took 10 years. And there was an actively enrolling Impella versus balloon pump study in the US that actually got canceled after that came out. Similarly, equipoise and randomization, heterogeneity within disease processes, in particular cardiogenic shock, like I mentioned. And then I've shown a lot about practice variability for PA cath use, things like that, even within what's considered some of the premier CICUs in the country. And in this, we detail ways to kind of get ahead of these issues. We also recently started a professional home in a lot of ways. We don't belong anywhere. We didn't belong in the cardiology world. We weren't always welcomed into the critical care world. So we started our own society and we had our first meeting. We've been around for a little over a year. We had this in Houston Shock, and we were really excited to have the APCCMPD, or Poland Program Director Society. Shoko probably, hopefully I didn't butcher that. At the first meeting, they've been a great partner. Here we detailed, what the critical care cardiologist is. Are they just an intensivist? Are they not an intensivist? And kind of next steps for our field. And then selfishly, want to hop back to the respiratory failure talk, which I mentioned at the beginning. Again, enormous variation in invasive, non-invasive, and high flow nasal cannula use at 3CTN sites. And a lot of that has to do with just there's no evidence in our patient population. For example, these are some high-risk extubation studies. So Hernandez in 2016, less than 8%, had heart failure. The JAMA 2019, the high flow versus combo for high-risk extubation, less than 15% had LV dysfunction, 7% were intubated for acute cardiogenic pulmonary edema, and then more recently, another Hernandez article where less than 3% had heart failure. So how do we treat our patients? We're really just extrapolating from these studies and using best guesses, but I'm interested and motivated to have our own evidence generation, and I'm very thankful to Dr. Fajardo, who's partnered with me on this extubate heart failure trial. It's a pilot, only 50 patients in both arms. We're randomizing patients with systolic dysfunction to either high flow or BiPAP on extubation, intubated for 24 hours, excluding patients with COPD or that are hypercapnic based on that JAMA 2019 article. We're going to be doing this in the MICU and the CICU and hoping to start probably June. When I started this talk, maybe I was being a little bit optimistic. So with that, I'll just show probably the patient 0 where I got whatever daycare Ebola I currently have. His mom is an ophthalmologist, so I'm trying early with the stethoscope. And then this is him recently in March in Rome, in the Orange Gardens. If you've ever been there, he found an orange immediately and just would not drop it. So I think I'm right on time, and I would be more than happy to answer any questions. Debbie or Shioko, are you there? All I see, I don't hear anything, and I just see the CME, or maybe there are no questions.
Just talk for yourself.
Can you hear me now?
Yeah, I got you.
All right. So, here. Here's Lauren with a question.
Hey, Elliott, Lauren Ferrante. Nice to see you. Thanks for being
Hi,
there. Hi.
hi, Dr. Fronte. You were my first co-attending in the COVID ICU that Shioko was mentioning.
That's right. Yeah, it was great working with you. I love seeing everything that you've done.
Oh,
So,
thank you.
nice. Sorry I couldn't see you in person, but I'm sure we'll see each other soon. So, thanks so much for the talk today. Mike, it actually wasn't a question about the content so much as your comment about finding a professional society home. And I did want to, we've obviously the ATS is very important for us as medical intensivists because it's pulmonary and critical care. But the Society of Critical Care Medicine has been really important in terms of, like, for example, in my work, advancing the work of aging in critical care, because it allows us to reach surgical critical care, anesthesia critical care, kind of critical care more broadly. And I do think there would be a home there for cardiac critical care. And I wonder, just from a professional development and growing this space standpoint, if you had thought about establishing a group there, or perhaps, establishing things in that society. And I'm happy to talk about that offline if there are other questions, but I kind of just wanted to plant that seed.
Yeah, thank you. And we would be fully supportive. I mean, I think we are a pretty collaborative group. I know of several colleagues that will go to that meeting yearly. But I don't know if we had the sense that there was a place to kind of implant our primary society there, but we would love to have a presence at the Society of Critical Care Medicine, and I'd love to talk offline.
Great. Here's Mark Siegel.
Elliott, I hope you feel better. And
Thank you.
if it's any honor, I can count at least 4 incoming interns on the Zoom list who haven't even started residency yet, who already got exposed to the Teacher of the Year. So that's truly incredible. They'll be ready to start in the CCU in a couple of weeks. So as you know, I'm really interested in the PA-CAF data, and at least in the medical critical care literature, it's such a definitive no. And I'm wondering if you can unpack, even in the context of observational data, why this particular population would be different. I know you get specific information in terms of things like cardiac index and SVR that's hard to come about any other way. But at least in the medical ICU, we basically transitioned from using PA-CAF to using other methods of assessing hemodynamics. And so do you have a sense of why the cardiogenic shock patients would benefit where other patients would not?
Yeah, it's a great question, Mark. And the first thing some folks would say is that it's not a therapeutic device, it's just diagnostic. And so if you don't know like what you're doing with these numbers, it's not going to help. I don't buy into that. I think probably the medical ICU folks like you probably know just as much, if not more, growing up with it. And my sense is just the cardiogenic shock patient population is so fickle, especially with mechanical circulatory support, that we're seeing a lot more RV failure. It's not just simple LV failure. As you know, about 40% of RV function is from the septum. And so almost all of our AMI shocks have RV dysfunction. It's just, I think, a much more complicated process than we thought. And why there's that difference in outcomes, they're just markedly different patients from the medical ICU respiratory failure to the cardiogenic shock. And who knows that although we've got a strong signal from our work and a lot of these registries that the outcomes are better, really we need a randomized controlled trial to see. But I would love to come throw in some PA-CAFs in the MICU.
So I have a question, Elliott. So one of the slides that you showed looked at the importance of trajectory. The sky stage going from a B to a D is different than someone who's staying a B to a B, or maybe started off D to a D, right? So the actual change matters. And I think that's very much true in what we do. Being able to sort of predict the future is, we all wish we had a crystal ball to know who is that patient who's gonna actually fall off the cliff. Are there work being done in the cardiogenic shock sort of space, trying to predict who is that person who's gonna be the falling off the cliff patient, right? In whom maybe this ties into the early versus late PA catheter use, in whom early use might be helpful to have some granular numbers that you can track alongside all of the other assessments that you're doing.
Yeah, yeah, that's a great question. There certainly is much smarter people than me using biomarkers and subphenotyping, even within what you consider your classic AMI, anterior STEMI shock. But what I think has surprised people is how early these trajectories can change. Within 6 hours, there's a matching study published in Circ Heart Failure from the Cardiogenic Shock Working Group looking at early trajectories. And I think that, unlike, say, STEMI, which has a clear 90-minute door-to-balloon time, that people didn't appreciate how early you really need to make decisions with cardiogenic shock, whether that's a PA cath or early mechanical circulatory support. Both Dr. Bana and a couple of the residents have another study looking at just this with our literature. And one thing, in addition to just, early PA caths or early mechanical circulatory support, but shock teams have become very popular. We have one at Yale. I think it's underutilized. And there's at least two single center studies and one retrospective but multi-center study showing that just the presence of a shock team, not anything granular about who's on the shock team or what decisions they made, just the presence of one at your hospital lowers mortality. And I think that that's pretty telling, that the need to have a multidisciplinary group to make these decisions. Cardiologists were very probably overly proud people sometimes that think we know how to manage shock, but really just getting multiple brains at one time to come up with early decisions. But more towards your question about like predicting who is going to fall off the cliff, there's a lot of people doing biomarker work and AI work, but nothing that I'm aware of that's anywhere near prime time.
We have time for probably one last question.
Hi, Elliott. This is Sheriff. It was a very interesting talk. I'm just trying to understand part that you said. In the trial, in that part that you talked about, heart failure with MI versus, shock with MI versus shock with heart failure. In that group, you said there is a super responder or some super responders. Now, the super responders include patients with RV failure and resistive load or not?
No, the opposite. So the super responders are people with normal RV function in general and high SVRs. So the balloon, is just going to be a univentricular support. And so it's not going to help anyone with RV dysfunction. And patients with higher SVR, generally quoted around 1400, seem to have a better response to a balloon pump. So sorry if I misspoke there.
So it was only so then the trial all shock that you said afterwards.
Yeah.
That tried to go with those conditions, just like.
Yeah, they tried, but I think they enrolled patients that were not sick enough to need a balloon, and so we're never going to find a 20% difference in outcomes. And I give them a lot of credit. The US, as you probably saw, has not had one mechanical circulatory support study. So this is all out of Europe because it's really challenging. But I just wanted, in case you hear this study name or someone quotes it, that it's unlikely to change anything we do in clinical practice.
All right, thank you again, Elliott. I hope you feel better soon.
Thank you, Shoko. And can I just say, just to the whole pulmonary and critical care section, how thankful I've been to many of you for the friendship, and I've learned so much from a lot of you. It's really one of the sections, if not the section, I respect the most at Yale, and just thanks so much again for everything and for the opportunity.